Okay, hello everyone joining in just now. We'll just wait a couple more minutes to see if we've got any late / perfectly on time attendees. And I will just get the presentation up and running just now. Okay, so there should be a section in your Zoom taskbar where you can type in some Q&A questions. So I suppose firstly, I just want to make sure that everybody can hear us and see the presentation okay? Yes, hopefully. Just wait one more minute before we get this started. Cool. Thanks, Jennifer. All right, so I will start by doing a quick introduction. So good afternoon or good morning, depending on where you are in the world. We've got people interested in the webinar as far as Russia and the United States, so that's great. My name is Corey Noble. I'm the research director at NewMetrica. I want to thank you for your attendance today or for registering to receive the recording of this webinar. Today, the webinar will focus primarily on chronic pain measurement methods for dogs. Because of this, there were a few questions submitted to us before the webinar that relate more specifically to treatment methods. And don't worry, we will address these with personal responses following today's webinar. Throughout the webinar, you're welcome to type any questions you might have into the chat box in your Zoom desktop, and we will do our best to address them after the presentation. And if you've got any follow-up questions, we will be sending out an email where you could contact us through that as well. So without further introduction, I now pass things over to Professor Jackie Reed, who is the CEO of NewMetrica, and she's going to walk you through measuring chronic pains in dogs.
Thanks, Corey, and thanks everybody for joining us. It's lovely to speak to you today. Now, before I actually start the presentation, I would like just to give you some sort of background as to the science behind the tools that I'm going to be talking about today and the people who've developed these tools. Now, working from the left, we have Andrea Nolan, who is Professor of Veterinary Pharmacology and also a specialist anaesthetist like myself, previously in Glasgow, but now in Edinburgh Napier University. We have Marion Scott, who is a Professor of Statistics in the University of Glasgow. Leslie Wiseman-Orr, Dr. Orr, who is an assessment specialist. And then we have Corey, who has already spoken to, and she's very involved, as are Marion and Andrea, in the future development and all the sort of extra work that we do with these tools. Now, first things first, when we start to design tools, we have to ask ourselves 3 questions. We ask ourselves, what are we trying to measure, for whom, and for what purpose? And in the next 30 minutes or so, I'd like to give you the answers to those questions as they relate to chronic pain. But first, Lord Kelvin, who was very, very involved with Glasgow University, he was a student and then he was a professor in Glasgow University, and he invented the Kelvin temperature scale, had something to say about measurement and the importance of it. And he said that when you can measure what you're speaking about and express it in numbers, you know something about it. But when you cannot measure it, when you cannot express it in numbers, your knowledge is of a meagre and unsatisfactory kind. So how does that relate to the clinical context? Well, I believe that unless we can recognize pain and measure it effectively, then we can't be confident that anything we do to relieve it is effective. And if we use osteoarthritis as an example of that, this chronic disease that causes a lot of pain and can affect 1 in 5 dogs. And we have a myriad of treatments that we can use for osteoarthritis, and many more actually being developed at the time as new molecules come on board. So it's very important that we have a useful, valid, and reliable outcome measure that we can create the evidence to suggest what treatment is working and what treatment is not. So going back to my original question, what we're trying to measure. So what is this thing that we call pain? Well, essentially, it's a multidimensional experience. It's not as Descartes way back in 1664 described it, as particles of fire moving up the body from the foot to the brain. Very much more complex than that. And it's also a uniquely personal and emotional experience. So that's the first thing that we have to consider. And it's something that is distinctly unpleasant. It has an affective dimension, and it's this affective dimension that makes you feel so bad. So that's the bit, if you like, that causes the suffering associated with pain. So pain is not just about how it feels. It's no longer just about the ouch factor, the intensity. It's about how it makes you feel. And this part, the how it makes you feel, is the key to modern measurement of the pain experience. Today we're talking about chronic pain, and again, it's a very individual thing. I have a chronically painful shoulder at the moment. Some of you may have a chronically painful shoulder, but for sure your pain is not the same as my pain. We cannot be sure what another person's pain feels like. But there was a really interesting study done, which was reported in the Scandinavian Journal of Pain, and what it actually did was it tracked these people with chronic non-cancer pain for a year. And one of the things that they asked these people to do was to draw their pain. And these are the kind of drawings that people produced that described how they felt. So here's somebody here who's got dragging a 10-ton weight about. On the left-hand side here, we have somebody who is trying to express how it affects their social relationships. There's all the friends chatting in the background, and they are feeling totally isolated. And then down at the bottom, we have the one where somebody has depicted how they feel when they don't have chronic pain and how they feel when they do. And I have to say, it looks pretty awful. But the sad thing about all this is after a year of treatment, 6 in 10 patients felt that the chronic pain controlled their life. And 95% of them, despite having been treated for a year, still were suffering moderate to severe pain. It caused depression in 67% of these people. So it's very clear that chronic pain has a significant impact on the quality of life. And indeed, people with chronic pain have reported that basically all the aspects of their lives are affected by this chronic pain. Here's somebody in this particular paper, they were talking about enjoyment, emotional well-being, tiredness, interrupted sleep, and so on. So in people, health-related quality of life is recognised as an important focus of measurement of chronic pain in people. And we believe that it should be in animals as well. But of course, we have particular challenges when we come to measuring pain, and not the least of which is the fact that our animals are non-verbal. They can't self-report, which is the gold standard in human pain measurement. But it has been said that behaviour is a form of self-report. And so a proxy, like Gillian here on the left-hand side, who is trying to assess pain in this Rottweiler, has to rely on judging the behaviour, looking at all of that to interpret how that animal feels. And then, of course, we have the added complication that all the different species manifest pain in a different way. But the biggest challenge that we have is ensuring that what we develop is scientifically sound. And we'll come on to that later on. Let's talk a little bit about proxies, because we need a proxy. All our animals need a proxy. And the conventional wisdom is that the best proxy is the person who knows the patient best. Now, in human medicine, there are categories of people who can't describe how they feel. At one end of the spectrum, we have infants, and at the other end of the spectrum, we have generally the older people who have cognitive decline. And the best proxy for them, it may be in the case of the baby, it may be the doctor, it may be the nurse, or it may be the parent, excuse me, and in the case of the older person, it would generally be a carer. For our animals, down in the bottom right-hand side here, you see a dog that is in acute pain. And for acute pain, the best proxy is undoubtedly the vet or the vet nurse, because they are most familiar with acute pain behaviour. But when it comes to chronic pain, then the owner is the best proxy, because the owner knows that animal best. And this is something that I want to emphasise, and this was some guidance that was produced by the FDA. And they stated that an owner cannot validly report a dog's pain intensity, but can report dog behaviour thought to be caused by pain. And I think this is very important. So the next time you see somebody being asked to score on a 0 to 10 scale their dog's pain, you think about that in actual fact, that measurement is not going to be valid. But that owner, and the reason for that is that what is happening, obviously this pain experience that's uniquely personal is uniquely personal to the dog as well. And it's happening in that dog's head, and unless that dog owner is able to read the dog's mind, which he can't do, then he can't report how the dog feels. But he can report lots and lots of changes, very often subtle, in the dog's behaviour. So what our health-related quality of life instruments do is that they turn the answers or the observations that the owner is making into numbers that we can treat statistically. So the instrument is designed to ask the correct questions. Now, it's a sad fact of life that whenever we ask any question, we risk a biased response. And with respect to pain, we generally infer pain in others by analogy. You know, if you've had a cruciate ligament repair, then you obviously, if you're then looking at a dog that's had a cruciate ligament repair, then you're thinking about how you felt. There's also a perception of the intensity of the pain making a difference. And people generally assume that soft tissue pain is not as intense as orthopedic pain. Now, it depends very much, obviously, on the soft tissue pain that you're looking, but that is what people tend to do. But in this case, when we're talking about the owner being a proxy for the measurement of chronic pain, then the strength of that human-animal bond is huge, and it increases the risk of a biased response. And it does so because either consciously or subconsciously, the owner will try to choose the right answer. It may be because they feel guilty if people think their dog has a poor quality of life. It may be that they're worried that if the dog appears too bad, then the vet will suggest euthanasia. Or indeed, it could be an excuse for euthanasia. The owner may be struggling to cope with his dog with chronic pain and doesn't want to admit it, but in actual fact would prefer if they didn't have to do that any longer. So when we are developing scales, we have to make sure that we minimize that respondent bias as much as we can. And there are particular techniques that allow us to do that, and we'll come on to them later also. So what about this ensuring scientific rigor, making sure that our instruments are scientifically robust? Well, excuse me, scientifically robust measurement scales have certain key properties. The first one is validity, and that's the ability to measure what it's supposed to measure. There are 3 types of validity. Criterion validity is where you compare your scale with a gold standard. But of course, in the case here, when we're talking about measuring pain, chronic pain in animals, we don't have a gold standard. So we can't do that. We can attend to the content validity, because that is established through the methodology that we use to develop the tools. And as part of that, there is an expert assessment. And the whole point about content validity is to ensure that all the items, all the questions in your questionnaire cover everything that is required, and that there's nothing that's extraneous. And then finally, construct validity. Now this essentially is a series of tests, and we look on a sort of continual basis for evidence to suggest that our scales have good construct validity. We can do it statistically. We can do a multivariate analysis called factor analysis. And what that does is it takes a lot of items that are related in one way to another, and it groups them into smaller groups, which are called domains or factors. So we can do that statistically. And then the other method of measuring construct validity is to do what we call known group testing. Now, essentially what you're doing is you're taking groups that should be very different, in other words, sick and healthy dogs, dogs before and after analgesia, and you're using your scale to ensure that your scale does reflect that change. Other key properties are reliability. The scale has to be able to give repeatable results, and that can be either inter-rater, where you might ask the same person to score a video, say, of an animal for over time, maybe 2 weeks after they've done it the first time. Sorry, that's intra-rater, test retest. Inter-rater is when you've got two different raters, and you should, if they're scoring the same animal, then their scores should be very similar. And then there's responsiveness, which is the ability of the scale, of any scale, to measure change when change occurs. Now, in healthcare, responsiveness has a particular meaning. And it's not about measuring statistical change, it's about measuring clinically significant change. So it's a clinically significant change that means something either to the patient or to the clinician, or in our case, where we have the owner as a proxy, to the owner. So how can we ensure that what we design has these properties? Well, we use a psychometric approach, which is the sort of tried and tested approach that's been used for human medicine in the last 30 years or so. And it's a phased approach. And I'm not going to dwell on this. I just want to briefly show you what is entailed. So phase one, you identify all the items, in other words, all the questions that you're likely to use in your questionnaire, or where you're going to draw the questions from. And this is generally done with the respondent. So in other words, with our chronic pain scale, we identify all these items from owners of dogs with chronic pain. We then go on to phase two, where we select from this very large pool of items. We weed it down and we select something that's more manageable. We then expose these to expert validation, and then we incorporate them into our instrument, which is a questionnaire instrument. And it's important at that stage to make sure that you pay attention to the layout, response options, instructions, and so on. Once we have that prototype scale, we then pre-test it. So we sit down with a number of respondents, usually between 10 and 20, and we go through the scale with them as they're using it. And we identify any problems at that stage that they have, and then we can go back and we can sort that out before we go on to phase three. Because phase three is a very important phase, and it's a large phase, and it takes usually quite a long time. And it's to field test the instrument to make sure that it is valid, it is reliable, and it is responsive. Unfortunately, it doesn't really end there. You know, you can have an instrument that's as scientifically sound or as valid as you like, but if it's not fit for purpose, nobody's going to use it. And so for it to be fit for purpose, it has to have what we call utility. And we can break down utility into these three parts. We can have acceptability. So for the person who's filling in the questionnaire, it has to be short, it has to be easy and quick to use, and it has to be understandable. Feasibility really relates to you as the vet, perhaps who is administering the questionnaire, because it has to be easy for you to do that, and it has to be easy for you to process so that you come up with a manageable score. And then the final thing is interpretability. What do the scores mean? And that is really, really important, because if you have a pain scale, you know, if it tells you a number, it gives you a number, unless you know what that number means, then the scale is actually of no use to you in a clinical setting. So now we can begin to put together what we would think of as the ideal pain scale. So it should be multidimensional. We've explained how it must get to how the animal feels. It should be valid, it should be reliable, it should be responsive, and it should be easy to complete the process. and it should be interpretable. So health-related quality of life instruments, what do they look like? Well, as I've said, they're structured questionnaires with some sort of formal scoring methodology. And they can either be on paper, historically they've been on paper, or now, in a sort of more modern way of doing, they're online. And lots of advantages with online, some of it to do with response bias, which I'll come to later, but also that one of the really important things is with the electronic data capture, then you can't have any missing data, which is often a problem with a paper questionnaire. The score can either be a single item score or it can be a profile of scores. Now, the disadvantage of a single item score is that it will tell you if the animal's better or worse, but it won't tell you any more than that. It won't give you any more information. Whereas a profile of scores does. It allows you to drill a bit deeper into the data and find out where, if you like, the quality of life is changing. And this is commonly used in the SF36, which is a generic scale that's used a lot, both in clinical practice and in research for humans. A health-related quality of life scale can either be generic, so that it will measure the impact of anything that affects the quality of life. So in this case, we're talking about chronic pain, but it also could be lifestyle, and it could be chronic disease. Naturally, because it is generic, it has a very wide application, and it's very often the only option when you've got more than one condition in a single animal. And interestingly enough, we've been looking at cats recently, and 40 out of 41 cats that we enrolled that had osteoarthritis also had between 1 and 7 comorbidities. So a generic scale scores very highly in a case like that. You can also have disease-specific scales, much more restricted application, of course, but in actual fact, they may be more sensitive to change than the generic ones. So what about VetMetrica, which is our health-related quality of life scale for dogs? Well, it's web-based and it's generic. It has 22 items in a structured questionnaire, which the owner completes in around 5 minutes. Data capture is online, and so is computation of the scores. It produces a profile of scores in 4 domains of quality of life: energy, happiness, comfort, and calmness. Energy and comfort, they tie in with physical well-being. Happiness and calmness tie in with emotional well-being. And then there is automatic generation of output for the vet and the owner. This is what it looks like, the system, and how it works in practice. So down at the bottom left-hand side, if I can work this mouse without changing the slide, down here we have the vet in practice who logs in the pet owner and puts in the dog details, and also sets how frequently they want the questionnaire to be answered. That information shoots into our server. It then sends a message to the owner, who completes the questionnaire in the comfort of their own home. As soon as they do that, the responses go into the server, and an algorithm is applied that produces the 4 scores. One report goes to the vet. The information also goes, to our research and development database, and that's because producing these tools is an iterative process. It just doesn't finish once you've done it. You then go on as you've got more and more data to improve them and refine them. And under some circumstances, it can be loaded into the case record. At the other end of the spectrum, it goes into the output goes to the owner. A much simplified output, obviously, to the one that the vet gets. This is just to give you an idea of what the owner sees when they're doing the assessment. And you'll see that the assessment is personalized to the dog. So this is an assessment for Moss. And it asks us how well this word, active, describes Moss as he is today. If we don't know what active means, we can hover over the definition and the word definition and get one. But it asks us to score it on 0 to 6, from not at all active to couldn't be more active. Now, response options are important because that's what actually allows you to give the amount of information that you want to give. And if you want to measure on a continuum, in other words, from the very best to the very worst, then you have to give the person the opportunity to do so. And if you use a dichotomous scale, in other words, if you just say, is your cat depressed, yes or no? Or if you use a categorical scale, is your cat depressed, depression mild, moderate, severe? These give you some information, but not a great deal. Whereas using an ordinal scale, as we do, which then asks you to rate how depressed your cat feels, is the optimum. And that's what makes one of the special features of vetMetrica, that it does measure on this continuum from very good to very bad. So it gives the opportunity to get the absolute maximum amount of information. It also gives the profile of scores, which, as I say, allows you to drill down into the information and see what's changing. Is it active and comfortable that's changing, or is it happy and content that's changing? And that gives you, again, some idea of whether the changes are physical or whether the changes are emotional. It minimizes respondent bias. Now, we'll never get rid of respondent bias, but we can do as much as we can to minimize it. And the web-based delivery is very useful because it only allows the respondent to go forward. You can't go back and look at what they've put for a previous question. We have enough questions in there that it's difficult for them to remember what they've put for question number 1 when they get to question number 21. And these questions, if you like, are made up of both positive and negative items, and they're all mixed up. So that helps. And then the fact that the scores are produced by an algorithm, it's not just a simple addition as most other tools are. It is an algorithm that weights the items in the first instance and then combines them in a specific way to produce the scores. And some of the items map onto more than one domain. So all of this helps to make it more difficult, if you like, for the owner to see how they can manipulate the scale. There's also an early warning system set in whereby if the dog's scores fall out with a predetermined level, this is calculated by another algorithm in there, then the owner will get an alert either by text or by email to say perhaps you should visit your vet for a checkup. But the most important feature of all is that this tool measures pain and quality of life from the dog's perspective. So it's actually getting to that affective part of the pain experience, how the dog feels about its circumstances. So does it tick the boxes? Well, yes, it's multidimensional. I don't have time to go into it here, but we have evidence that it's valid, reliable, and responsive in a selection of conditions. We've looked at it in osteoarthritis, looked at it in lymphoma in dogs, looked at it in obesity, and there's no reason why it shouldn't perform well in other chronic disease conditions. It's easy to complete and process because it's all online. And the last one we have is interpretability. So how do you interpret it? Well, I'm going to use this as an example. This is just a dog with osteoarthritis that was treated with non-steroidal anti-inflammatory drug. And you'll remember that the owner filled in the responses on a 0 to 6 scale. So what we do is we transform these to 0 to 100. And we do that so that 50 is the average healthy dog. So here we have the graph that the vet gets, and you'll see here are all the different domains of quality of life. And you can actually take them out one by one. If you want to look at 1 or 1 or 2, you don't have to look at the whole picture together. And we have here the 50, sorry, keep doing that, sorry. We have here the 50 line, which is the average healthy dog. And then we have this dotted threshold line. And what this means is that 70% of healthy dogs in that age group will score above that line. So at a glance, the vet can look at the dog and see exactly where it comes in relation to the healthy dog population. Now, the other thing that we look at is this minimum important difference. And we calculate that. And what that means is At the moment, it's sitting at 7, which means that if your dog improves by more than 7 on the scale, then you can be reasonably sure that that is a clinical difference. In other words, it might give you some information as to whether you want to keep your treatment the same or indeed you want to change it. So these are the methods that we use to allow you to interpret the scale. So what are the applications in veterinary practice? Well, it can be used as a routine monitor, and I think it fits very well into a wellness package. It allows continuous assessment over time in between the visits to the vet and measures whether or not the health is improving or declining. It does allow these alerts to alert the owner to something going wrong. But this is at the discretion of the vet. It doesn't have to put the alerts in, because one of the disadvantages is that these are obviously done on a group basis, and there'll be some old dogs in there that will always alert because of the state of their health. It is possible to create personal alerts for individual dogs, but that is something for the future. It's something we haven't done as yet. So it gives the owner confidence between visits. It can also be used by you, the vet, as a clinical monitoring tool to look at how efficacious your treatment is. And finally, it can be used on an individual basis to help inform that difficult discussion around whether or not animals should be put to sleep. Because I think if the owner can actually see something tangible, then it's bound to help that situation. So what about clinical trials? In human clinical trials, as you can see here in this excerpt from this paper in Pain, comprehensive and psychometrically sound patient-reported outcome measures, consistent with the multiple impacts of pain on everyday life, are needed to evaluate pharmacologic and other interventions for chronic pain. Now, we obviously can't have a patient-reported outcome because our patients are non-verbal. So what we have is an observer-reported outcome. And there is some evidence that we should be doing this in veterinary medicine. This was this group of orthopedic people who got together and to try and look seriously at outcome measures for orthopedic trials. And they came up with this guidance, and they suggested that, yes, it's important to measure functional outcomes, and that can be done by a variety of methods, including validated observer-reported functional instruments, but also that each study should include at least one validated and readily available observer-reported quality of life outcome measure. Now, when we think about the functional outcomes, then for osteoarthritis, for orthopedic disease, then there are a bunch of these, and the first three, the HCPI, the load, and the canine brief pain inventory, they've all been validated up to points, different points. And then we have the client-specific outcome measure, which is used often, and what essentially the owner is asked to pick 3 things that affect the animal because of the condition and score these on a 0 to 4 scale. This is not a validated scale, and it has a lot of disadvantages with it, which we'll come to later. And of course, Vetmetrica is at the moment the only validated and readily available quality of life instrument. Now, veterinary clinical trials, observer-reported outcomes are bedeviled, if you like, by the placebo effect, where the placebo group has a high proportion of false positives. And so it's very difficult often to prove a statistical difference between the effect of the treatment and the effect of the placebo. And the sort of end result of this is that you have to use a lot more dogs, and of course that increases the costs. Now, if I can just use this example, here we have the first 2 on the left-hand side graphs are from a study done by NexVet using their monoclonal antibody for dogs with OA. And they used a client-specific outcome measure and also the canine brief pain inventory. Now, looking at the client-specific outcome measure, what we have here, if I can find my cursor. The blue line here is the success rate in the placebo group, the percentage success rate. And you can see, and this one is the treatment effects, the orange one's the treatment effects. So you can see that very high placebo effects, so lots of false positives in that placebo group. But enough of a difference here between the treatment effect and the placebo effect to actually have a statistical difference that will say, yes, the treatment is effective. If we look at the other outcome measure, which was the CBPI, we can see there is still a reasonably high placebo effect, but again, a statistical difference between the treatment and the placebo group. If we look, on the other hand, at vetMetrica, now this is a very small placebo-controlled trial that we did with a nutraceutical, and you can see that with vetMetrica, the placebo group, or the placebo effect is much lower, and here's the treatment effect, which is higher, but not enough higher to demonstrate a treatment effect. So if we go on to see what the effect of that is, if we look at another study where Parnell announced the results from their efficacy study for Zyvax, which is a disease-modifying agent for osteoarthritis. And they used the canine brief pain inventory. And what they found was that their treatment success was 54% overall, and their placebo success was 35%. But again, there was enough of a difference to demonstrate that there was a statistical difference between the two. So, okay, if we do a bit of modeling here and just modeling numbers, and we look at, I've done two graphs here. I've got the placebo success is 35% and the treatment success is 54%. So this, and the power of this study, I want power of a study as 80%. So what this shows is that with the placebo success of 35 and the treatment success of 54, I need 107 animals to show a statistical difference between them. If I reduce that to 20%, then but keep the treatment success rate at 54, the difference is that now I can get away with 31 animals as opposed to 107. So it makes a very profound, decreasing the placebo effect makes a very profound difference to the number of animals that you need to recruit for your study. Sorry, same slide. Now it's not all about costs. In the future, there's likely to be a lot more use of natural animal models of human disease being used in clinical trials, because there's a big failure rate at the moment between the basic and the preclinical research, probably due to the fact that it's rodent models that are used, which are very different from human. So if we can use the natural animal models of disease, then that is likely to improve that remarkably. And there's a lot of interest in that at the moment. And this was a particularly interesting paper I read, which was about translational models for human diseases. And they quote a tremendous number of cases where in actual fact animals are good models for human disease, osteoarthritis, cancer, and so on. So I think in the future, there may be much more of this. And of course, the key to the success of this is to have good outcome measures. I thought I would just finish up with some case examples to show you with using vetMetrica. And to start off with osteoarthritis, this is Harry, and he was a 9-year-old crossbreed, presumptive diagnosis of osteoarthritis. Now, here were his initial scores, and then his owner went traveling for a few months, and when she came back, she thought he had deteriorated, and sure enough, his scores show that he had. She then put him onto a short course of tramadol and gabapentin, and his scores improved. She took him off that, and his scores deteriorated again. Now, the reason she hadn't used a non-steroidal in the first instance was because he had a kind of dicky tummy. but she thought she'd try him on a non-steroidal, so that's the result that you see here. He shows an improvement and then a deterioration. He was then diagnosed with idiopathic Addison's disease, went on to steroid, and you can see how his results improved again. Here's an 8-year-old Rottweiler with spondylitis and back pain who was maintained for a long time on meloxicam and tramadol. And when I was looking at this, just looking at the longitudinal results, I thought there's something happening in here and there's something happening in here. And when I spoke to the vet, it turned out that at this point he had had a course of 6 laser treatments and his meloxicam and tramadol reduced. And you can see that certainly with his physical side of things, he had improved. He then deteriorated after that, and the owner had another dog that she'd bought a course of 6 treatments for. He wasn't as good a responder, so she said, oh, just give it to Buzz. And so Buzz had 1 more laser treatment, and you can see how his scores improved again. And this is a fairly new one, and I'm very grateful to Davis Specialists for lending me this case. And this was a 9-year-old German Pointer with end-stage stifle. And he had a marked deterioration in March when he was diagnosed with 3 chronic cervical discs. Originally did better, and then he deteriorated, at which point the owner was wondering what she should do. But then they increased the interventions, increased gabapentin, acupuncture, laser, hydrotherapy, and you can see how that is reflected in the scores here. And the owner now is very happy, reports that the dog is on a good plateau, if you like. And I think it's quite clear how this is borne out by the data. Just to remind you that health-related quality of life tools are not just for chronic pain, they're also about lots of other chronic disease. And this is just a dog with lymphoma, non-painful cancer. And you can see here that when he was admitted to the clinic, his scores were very low indeed compared with the normal. And this sort of ties in with the fact that his substage was B, so he had lots of clinical signs at this stage. He then was put onto chemotherapy and improved, reached a plateau when he was in remission, and then had a bad dip. And this is where he had a perivascular injection of incristin, so he had a badly damaged leg, bad slough and so on, reflected in the scores, and then over time that improved, and he was lost to follow-up here, so he was actually doing well at that stage. So if you like, my take-home messages are that measuring chronic pain through its impact on quality of life encompasses the whole pain experience, which is very important because we're getting the emotional part as well as the physical part. It's not just restricted to pain. And that the development of these robust instruments to measure pain and quality of life is not simple. I hope you realize that now you've seen what we put into it. It is time consuming and it's expensive, but it is essential, I hope you'll agree, to meet the needs of modern veterinary medicine and drug development. And now I think we're at the any questions stage.
Yeah, thank you so much, Jackie. That was fabulous. I will just check. We have one question that was pre-submitted, and that is, Jackie, why do you think that the placebo effect is so low in VetMetrica's instrument compared with others?
Well, I think it's related to the fact that we have managed to decrease the respondent bias. I think we've made it really difficult for the owners to either subconsciously or consciously manipulate the scale. And this was my theory, and quite recently I gave a presentation to the Association of Veterinary Anaesthetists, and one of the other plenary speakers was a medical colleague who is very involved in measurement of pain, and she talked a lot about the placebo effect and response bias. And when I spoke to her afterwards, I asked her about my theory of the response bias decreasing this, and she agreed that that was a possibility. So I felt a lot better. but somebody else in another position agreed with my thoughts. I think we've also got another question, Corey.
That
was it.
Oh, okay.
Which was one that came in later, and I just thought I'd pop it on the slide. And that was, how can you distinguish pain from the physical limitations to flexibility that can develop in arthritic joints? And I think the short answer to that is you can't. But we can look at the influence of decreased flexibility. Now, I've just kind of put together this slide to show you that when we're working with these variables that affect quality of life, we can put them into two kinds. We can have causal variables and we can have indicator variables. Now, causal variables are essentially things that will cause a change in quality of life. So it might be an environmental aspect, it might be a disease aspect. These will affect the quality of life, so they are causal. Indicator variables, on the other hand, are variables which will indicate to us that the quality of life has changed and hopefully give us some help in measuring that. So all our 22 items are indicator variables. And the question is, if you like, so what's flexibility or lack of flexibility? And the question is it causal or is it indicator? Well, there may be a causal aspect to it. You know, decreased flexibility may induce some pain, but there's a lot of indicator variability in there as well, because an owner who is scoring with our scale will answer questions which are very much related to flexibility. So they might be asked to score activity, they might be asked to score stiffness, they might be asked to score lethargy, you know, all of these things that will be affected by flexibility. So flexibility is very tied up with quality of life, but it should come through within our scale.
Perfect. And I think we've got a few questions submitted on the Q&A. Give me just a second to look through this. All right, so we've got a first sort of question from Patricia Templeton. Give us a minute to read this. I suppose that's more a comment.
Thank you.
Thank you so much, Patricia. And from Derek Flaherty, can the health-related quality of life be adapted for other species?
Well, no, is the short answer. The dog one can't be. But the methodology that we use to produce these scales is generic. So we can go back to each species. If you remember, we talked about how each species manifests pain in a different way. So we go back with our generic methodology and we start at the very beginning with the pain behaviors, if you like, for the different species. And we've been doing this for the cat. Corey has been very involved in this, and we now have a cat quality of life, generic quality of life scale, which just very recently went online.
All right, so the next question is from Rosalind Wrightston. What is the cost to the vet to use the VetMetrica health-related quality of life? I suppose, Rosalind, we have a basic price structure, which I'd be happy to email you, but it is based on sort of case to case.
Corey is absolutely correct with that, but you can also access the scale in the Zoetis Pet Dialogue app, and we've recently upgraded the system and to make it more sensitive and also to improve the owner output, and they will be doing the same in their system as soon as they can set that up. This only happened with us in the last few weeks, so that's another way that you can get hold of the scale. As to how much it costs you for that, I'm sorry, I don't know. So it's really up to yourself whether you want to just check that out in the first instance.
All right, the next question is from Jerry or Gary, apologies, Polton.
Jerry.
What do we do if we want to discuss using this in our practice?
Essentially, contact us. You'll find our email on our website, which is www.newmetrica.com, but you can also email either Corey or myself directly, which is just like corey.noble@newmetrica.com or jackie.reed@newmetrica.com, and we will discuss that with you.
All right, and our final question is from Karen Menzies. Given that pain and stress present so similarly, apologies, could this questionnaire be used to assess behavioral problems, stress, and anxiety?
Yes, I believe it could be. I've actually had some discussions with some behavioral specialists who are obviously very interested in health-related quality of life, and the consensus is that yes, indeed, it could be used. The interesting thing, or one of the good things about this, is that the animal acts in its own control. So you're looking at, as with so many measurements, trends are more important than individual results. So if you have an animal that is uncomfortable because it's in pain or because it's stressed or a combination of the both, and you're treating that, then looking at the animal longitudinally with the health-related quality of life scale will give you, again, insight into how your treatment is performing.
Perfect. And the last question that has come in right at the last minute is?
Well, essentially, excuse me, we've had conversations with both the FDA and the EMA. With the FDA, we have been in discussion with them for over 2 years, because electronic data capture, a tool that uses electronic data capture, is new to the veterinary division. And so it's important that our tool complies with the regulations for electronic data capture, 21 CFR Part 2. And so we have established with them that we have developed the tool in accordance with their guidelines, and we have also settled that we will produce, or if somebody wants to use it in a clinical trial, then we will supply the necessary data for the FDA to rework the calculations in a secure master file. So everything has been set up in accordance with that, with the FDA. We've spoken to the EMA, and their system seems to be somewhat different, but they have suggested that at the time when somebody wants to use it, then they will obviously look at it seriously. And hopefully, because the FDA are happy with it, then EMA, I would have thought, should not be that different. Several years ago, we had a conversation with the VMD in the UK and demonstrated the tool to them, and that was before it was at the stage it's at now. And they gave us a statement to say that they would be happy to look at any studies which came forward which were using the tool.
All right, Jackie. Well, thank you so much for your time, and thank you everybody for joining us for our first webinar. We hope to have another webinar up and running soon, which we will keep you all informed of. And a follow-up email will have details of where you can access this recording, as well as will be uploaded to the www.newmetrica.com website for you to look at later. So again, thank you everybody so much for joining us, and I hope you all have a fabulous day and found this informative. And now we will end the meeting, and I hope everybody has some sunshine where they are. It's sunny in Glasgow today, so we're going to go have a quick coffee break and
enjoy it. Thank you very much, everybody.
Bye.